our webinar today is telehealth, quality and patient safety aspects of telehealth. When we're talking about remote provision of care, which we know as telehealth, it seems everyone is quite familiar with it, especially after COVID pandemic, which basically forced every medical facility into this new reality to provide care remotely. However, when we deep dive into the subject and start asking ourselves what are the practical aspects of it and how to make this provision safe, there are actually more questions than answers. That's why we decided to devote our webinar today. By the way, today we have an anniversary. It's our webinar number 30. So let's celebrate it together. We decided to devote this webinar to this topic and invite experts who will share their experience in working with telehealth, will share their knowledge about the regulations in telehealth. So basically do everything so that you in your facility can start making telehealth services safer for your patients already starting tomorrow. So now I'm happy to introduce our first speaker, that is Raju Narayan, our colleague. You might have already seen him many times, global health sector specialist. And Raju, you're welcome.
Thank you, Julia, and good to meet all of you virtually. My role as the global health sector specialist, so when we look at healthcare investment across the globe, in healthcare delivery or healthcare provision, telehealth has become part and parcel of that healthcare delivery today from where it was maybe a few years back. So I just want to give you a quick overview of how we see it across the globe, how I see the evolution of telehealth and what it means to different people in different geographies and different providers, and some of the potential challenges and risks and opportunities which we see in that space. And then my fellow panelists can dive deep into some of the very specific aspects of telehealth. So telehealth by itself is not a new concept, right? It has been around for many years, but in different forms and shapes. And it's a very loosely used terminology, if I may say so. It means different things to different people, different geographies. You talk to different providers, you know, they will define it very differently. And it, in its simplest form, as a teleconsultation or virtual care or online care, but the adoption of telehealth in the healthcare space has been relatively poor in many years back compared to many of the other service sectors. For example, you know, people are very used to doing virtual or online service delivery for your banking and shopping needs, retail therapy and stuff like that. But when it comes to healthcare, traditionally it has been an in-person care for many reasons, right? One is it could be that you know, you don't feel comfortable talking about your healthcare needs or whatever virtually, or maybe the infrastructure was not available, or when you're sick, you just want to be taken care of by in-person. So it could be many, many different things. Whatever it is, the adoption was very poor, and people still try to travel long distances and wait in the waiting room to see the doctor, still feel happier than talking to somebody virtually. So that has been the case. But now we fast forward to 2020, when COVID came, and virtual care became a necessity rather than a nice to have an option. So the adoption increased exponentially. This is both good and a challenging part. Why I say that is when adoption runs ahead of regulation and compliance, that poses a huge challenge, because suddenly everybody is using it, everybody is providing it, and so you don't know what is the extent of this challenges and risks are, whom you can trust, whom you cannot, and so all this comes into play. That's what I meant by when adoption runs ahead of regulations. And many countries have faced this, right? Because nobody expected the adoption to increase exponentially. They thought, okay, we can take it in phases, but no, that was not the case. So before we get into some of those challenges, I thought I would just try and define what telehealth or telemedicine means to different people. So let's say if you look at telecollaboration, which is basically talking about interaction between facilities or providers, professionals, when they talk about clinical referrals, co-diagnosis, or second opinion. So that's on the professional front between facilities or collaborators, that we call it as telecollaboration. Then comes to teletreatment, which can be in its simplest form a teleconsultation, or it can even go beyond that to examination, diagnosis, and even providing or assisting surgery remotely, like your robotic surgery. So teletreatment is another very big bucket. Then comes telemonitoring, which is monitoring of patient parameters, whether vital signs, directly from the patient or through the caregivers, for management of chronic conditions, hypertension, blood pressure, or diabetes, or even heart diseases. So that is telemonitoring part. Then you do have the other bucket of what you call as telesupport, which is may not be purely clinical in nature, but it can be educational, administrative, or counseling for the patient or caregivers. So that's another form of telehealth. And then last but not the least, you have telehealth products like your wearables, devices for remote monitoring and for mobile applications. So it all comes under the tele product. So if you see that the range of what telehealth means is huge. And each and every one of these buckets has got its own nuances and the challenges, opportunities, risks, and regulatory needs that are associated with each and every one of them. So if you look wide and deep, it's a very big ocean, telehealth is. And the good thing is that patients today are increasingly open to such form of patient engagement or patient engagement channels than the traditional in-person care, which is a good thing, which means that there is room for this to grow, but in a very cautious, systematic, and a structured way. So now let me go into what are the challenges I see when we look at such provision of care across the globe. It starts with the very basic fundamentals of healthcare delivery in terms of patient identification and provider identification, because how do you know that you're talking to the right patient? How do you know that you're talking to a doctor? You don't know. But when you go into a hospital or a clinic in person, yes, some of these things you take it for granted, that patient verification is very intuitive. You know how to verify a patient. You look at their IDs and stuff like that. You can verify them, and you know that this is a doctor whom you since he or she is sitting in a clinic and in a hospital, must be a physician. So you have that what do you call that, intuitive trust. But then when you do it remotely, you don't know whom you're talking to, and you just hope that it is the right person, both ways, right? Both from the provider and patient. So even to establish that patient identification, it's a big challenge. You need to have protocols. You need form. How do you make that foolproof? So I think that itself is a huge risk, and you need to have strict guidelines to establish the provider and the patient. So that's one thing. Then comes to the consent, right? When it comes to patient consent, what does that mean when you do remotely? How do you know that this patient is consenting to the consultation or treatment? It becomes challenging if let's say the patient initiates the teleconsultation. That's what we call as implied consent. But then if the patient is being brought in through a caregiver or whatever, you don't know whether the patient is being. So you need to have protocols again to establish that explicit consent from the patient. And these are some of the nuances people overlook. The other bigger challenge is that, in terms of the physician's licensing or the geospecific coverage and liability. You are licensed to operate in a particular geography. In person, no issue, right? Because the patient comes to your clinic, so you are doing you are providing care within your licensed jurisdiction. But then when you provide care remotely, what does that mean? Are you violating some of these licensing requirements? If you are providing care for a patient who is sitting somewhere else, are you liable? What is the extent of your liability? These are questions which are very, very critical to telehealth when it comes to that coverage and liability issue. The other biggest challenge which I face is the scope and limit of treatment. What can you do via telehealth or virtually? How far can you go? Should I do this? Should I not do this? Needs to be very well defined, right? Because when you look at in some cases, it's very well defined. I've seen like, okay, you have to do your first consult in person. Only reviews can be done virtually. Or, what kind of medications you can prescribe when you do it virtually. Can I prescribe and when do I initiate an in-person? How can I continue seeing the patient virtually, or is there a strict protocol of when should I ask the patient to be in person? And what kind of patients? I mean, even the age, right? Can I see pediatrics and infants or elderly? Can I do it virtually, or should it be a certain extent? It should be in person. So all these needs to be defined, and these are things which people usually take it for granted and do things in a very casual or carefree manner, which can lead to a lot of vulnerability when it comes to the providing the care. The other big challenge is data protection, data security. I can't say enough of that, because that's a huge, huge challenge when it comes to transferring of patient information, across facilities, across, remotely, and how is the data being secured? How is it being used? And these are concerns which both the provider and the patient has when it comes to this kind of data security and privacy. The other challenge is in terms of the payers, right? The insurance coverage issues associated with telehealth. That's another huge bucket. A lot of insurance companies, they may not cover telehealth, or they may not treat telehealth as a reimbursable care model. So that needs to be addressed, and look at how that can be put in place. And again, all these comes into place as to the extent of coverage and how well and how deep these coverages are. So that's another challenge. Then you have your technical issues associated with telehealth in terms of infrastructure, system malfunctions, and your bandwidth, your IT connectivity and stuff like that. That's another, and all these needs to be properly maintained and taken care of in order to provide a seamless care between the provider and so all these needs to be looked at when we look at providers say that they are providing telehealth or telemedicine service. These are some of the things which you look at and see how safe and robust the system is, what kind of systems they have in place in order to make sure that at the end of the day, we don't want to do any harm. Telehealth should actually complement your healthcare delivery, not become a safety risk, per se. So I think that's the biggest that's underlying principle behind this, because the other things which is also very critical is in terms of training and education, both for the provider and the patient, right? Because physicians and nurses, they are trained to treat a patient when the patient is sitting in front of them. We talk about bedside manners, soft skills and stuff like that, but the patient is remotely. Sometimes it's not common sense or intuitive. We need to be trained to treat the patient remotely. How do you deal with the patient's emotions psychologically and the patient care? So the training and education is another big part of providing care virtually. At the end of the day, the message which I want to convey is that it's a convenient way of providing care, no doubt about it, because you can get to the care provider very quickly, easily, without going through some of these logistical challenges. But convenience should never compromise compliance. So I think that's a key message. So we need to make sure that it's a convenient way, but we need to make sure that it's compliant to regulations and safety standards and mitigate the risk so that it It complements an in-person care. But the bottom line is, despite all these challenges and risks which I mentioned, it is telehealth or virtual care is here to stay. It's not going away. It's going to be there. That is the future. Whether it will replace inpatient care, the answer is no. Will it complement? The answer is yes. So end of the day, I say the future is going to be a hybrid model. It's not going to be a brick and mortar alone. It's going to be a brick and click model, right? So you need to work together. So that's going to be the future. I think with that, I will pass it to my fellow panelists to dwell deeper into some of these concerns. Thank you.
Thank you very much, Raju. It was very useful that you actually outlined and described all the possible challenges of telehealth. Because basically, when you think of telehealth, what is telehealth? Just communication between two people using social network or video or call, whatever. What can potentially go wrong at first sight? But after your speech, I understand lots of things basically can go wrong. I'm actually scared. And that's why I'm happy to introduce our next speaker, Dr. Zeeshan bin Ishtiaque, the CEO of Shifa Hospital, Pakistan. Dr. Zeeshan, please help us clarify this issue. How can all these components work out right?
Thank you, Julia, and thank you, Raju. I think I would say that I will try to build up on what Raju has mentioned about related to telehealth. So I hope you can see my screen, right?
Yes, we can. It's perfect.
Yeah. So thank you. So first of all, thank you very much. Thank you. And it's indeed my privilege to talk a little bit about and build up on what Raju has said. Just before we move on, I would like to echo my colleague Raju in saying that telehealth is going to stay. And that's what the Fortune Business Insight and Market Research Report 2021 says. With a market size for telemedicine by 2027 would be $396 trillion, with a compound annual growth rate of 25.8%. So the market is growing, so are challenges. And it's important that how we can tall amongst competitors, one, but the most important part that Raju has mentioned about that how to help organizations and how to deliver safe healthcare through telemedicine and then stay in the market. So I feel privileged and honored to be part of that wonderful team who helped envision eShifa. And the idea behind eShifa was to answer this issue of access to healthcare. Because we have seen in the developing world that we have healthcare providers, we have healthcare facilities in major cities, but once you go remote, you don't have access to healthcare. And with this technology and mobile services and data services coming in, so how to resolve this issue of access to healthcare? And that was when we envisioned eShifa. So building upon what Raju has talked about, that we envisioned it as a home healthcare organization with a hub and spoke model, with that being connected to a tertiary care hospital and hospitals. And then it was grounded in technology. And we thought it a little bit about it as Uber of healthcare. So that's how that was a mantra that we used while we were discussing it in early days. So I would say that before 2020, it was quite difficult for people to understand and realize and accept this reality. But when COVID came in, the entire universe conspires to make it a success. And all of a sudden, after COVID, we found out that the acceptance and the acceptability started, it increased absolutely 100%. So what was the scope at that point in time? So we talked about, and we had teleclinics, so that's one. And then we had multiple models. The model was it would be total virtual and it would be hybrid clinics. So that was one. Then we also had a provision of having a COVID clinic as a screening clinic. We used to call it Fori Mashwara, immediate consult. That's the translation of Fori Mashwara. Then we had home lab services, that is phlebotomy services, home pharmacy services, pharmacy delivered at home. Then we had home nursing services, that those patients, low acuity patients that can be treated at home. So it makes a lot of sense that they are discharged early, they go home and get the treatment over there. That reduces the cost, that improves patient satisfaction, that improves, but it has to be safe early discharge. Likewise, home vaccination services, home physio services, home monitoring services, elderly patient care, diabetes care plan. We clubbed it under chronic care programs, and then mother-baby care plan. So, as I mentioned earlier, that we envisioned Shifa as an answer to access to healthcare, but we really wanted it to be grounded in technology, but fully backed up by quality. And that was that we wanted it to be Joint Commission accredited before even it was the first patient was seen. We said that we are going to follow certain standards, and we took Joint Commission as the standards, and we got it accredited within 6 months of its operations. We got it accredited by Joint Commission as a home healthcare organization. So it was that, and then we also found out that Joint Commission launched its standards on telehealth. So, and they will be applicable with effect from 1st of July 2023. So currently they are not applicable. So we participated and we volunteered to be one of the pilot organization for testing of JCI telehealth standards. We understood and we believed that it required a lot of courage even among ourselves to invite external eyes into your organization and ask them to evaluate against standards. But we participated because we wanted to see that how well or how bad are we performing. So this was the eligibility criteria. So I won't go in the details. So it has to be fully accredited. So we were accredited by Joint Commission on Home Healthcare Standards. It provides asynchronous telehealth, that is store and forward interaction. So we had that in some way. Then provide synchronous care, that is real-time health interaction. We talked about teleclinics and all that stuff. And then mobile health, supporting patient care using digital applications. And then in-home devices to patient portal data transmission. So that was not what we were doing, but we were definitely thinking about when we had plans at that point in time, and still have to go for telestroke and go for other remote patient monitoring, all that stuff. So I think Raju is very, quite eloquently has mentioned about all these areas. So these are the area of focus in the standards, and I would say there's no absolute right and wrong answer to all these questions. It all depends upon organizations. It depends on the ground realities, how you take it. There can be multiple ways of meeting the standards. There is no absolute right and wrong that this is how you need to do it. So there are two types of standards. One was patient-centered standards, and then the other one was healthcare organization management standards. So let's talk about a little bit about about patient care standards. So there are four major areas: international patient safety goals, patient identification, already Raj talked about, patients' rights and responsibilities. That's extremely important. That what are the patient's rights and what are the responsibilities in telehealth? So we need to look at it from that perspective. Then access to telehealth care services, and I'm going to talk about each one of them separately, and I would like to build up on what Raju talked about related to the scope of services, how to gain access, when to seek medical care, and all that stuff. Medication management and review, all the way starting from how are you going to evaluate patient, how to make a plan of care, then moving forward, how you are going to prescribe it, how you are going to then do an appropriateness review, then how you are going to dispense it, and then how you are going to administer it. So we were a home healthcare organization that was accredited by Joint Commission, and we had all those standards in place. So it was a little bit easier to really transform from here, because to apply to them to telehealth standards. Then extremely important, governance, strategy, oversight, compliance, regulatory affairs, all that stuff. Information system and equipment management, big time. How you are going to do all that. Quality, data collection, continuous improvement, it's a journey and it's not a destination. As we always say, that even if you are accredited by any organization, by A, B, or C organization, it's not that you have reached somewhere. So it's a continuous journey. It's always there. There will be organizations that are accredited at this level, and there'll be organizations that are at that level. So it's a journey and it's not a destination. And then about staff qualification. So a little bit about these aspects of patient identification. Raju talked about it, improved communication, handing over, taking over, if there are any procedures at home, because we were a home healthcare organization, how, and if you're using technology for that, so how you are going to make sure. So these were the main areas. Some of them were applicable to us, especially the safe surgery part, but moving forward, yes, there are plans. So it was a little bit easier for us because we were a home health care accredited organization. So our compliance, it was easy to roll over from health standards to this. The other thing was, I won't go in the details about the scope of service. It's extremely important, echoing my colleague Raju in saying that it's extremely important that what you cannot do. You need to define as an organization that what you cannot do, what you can do, what you cannot do, because what type of medications you can provide, you can give IV administration at home. What can you do at home? What you cannot do at home? How you are going to manage patients? What about equity of patients? What if anything goes wrong? How to call for help? What are the other resources available? So it's extremely important that we identify the scope of service, and then we make sure that the staff knows about it, the patients know about it, and everyone, and we are on the same page. And so that's the first component. Then moving on, screening patients. Once you say that this is our scope of service, how are you going to make sure that you screen patients and you make sure that whether this comes under your scope or not? So we use Fori Mashwara, and we develop questionnaire, we train staff on that, how to do that. We try to make sure that the information goes out to people as well. Then history and continuity of care. So since we had an EMR, it was easier to really make sure that the history is there, there's continuity of care, all that stuff. But what is the minimum content of assessment? What type of patients do you see? The scope of service, how you link them with and incorporate that as part of your history. Emergency services, when to call for help, what are the closest areas? How are you going to call the ambulance? How the staff will know that we are backed up? Where the patient will land up? And since it's telehealth, so it also depends, and you need to identify that which patient is in which geographical areas, and then how you are going to make that information of all the services that are there accessible to the staff who are at this level, at this end. And if it's a home healthcare admitted patient, so if any staff is there, they need to know that how to call for help, how to refer patients somewhere. Then information system and equipment management. I'll try to be brief. So security of portal, so how to make sure that that we provide there's data safety, how to make sure that if there's electronic medication system, interoperability with third-party system, it was a challenge for us, it remains a challenge for us, and we are working on that, how to move forward. Interoperability, so how things would be interoperable, that's extremely important. How are you going to do an annual risk analysis? How are you going to collect data for that? So we completed the first exercise. Moving forward, what are the technology risks? So there are lots of benefits, but are there any? How are you going to identify a patient? How are you going to identify providers? What Raju mentioned about. So evidence-based multi-factor authentication. So we try to implement that. Encryption and roadmap to decentralized data storage. That's a challenge, but all sorts of things. Informatics, interfacing of instruments, equipment with informatics system. How are you going to capture, display, transmit, and then retain data? So so these are the things that, and as we always say, that this is a journey and this is not a destination. And then telediagnostics. I think Raju talked about it, so I'm not going to go in detail again. Then patients' rights and responsibilities, consent. We redid our content of the consent. Then how to embed that in the application and in the workflow. How are you going to manage medication system? So especially pharmacy workflow for reconciliation, we needed to do a little bit redo of that. Then quality data, it's how you're going to make sure that you have improvement strategies, everything is in place. Other areas, governance strategy and oversight, laws and regulations, one has to make sure that as part of our compliance and oversight, we need to make sure that what are the laws. We need to have a clear-cut understanding of the law and regulation worksheet, what is applicable on us, how it is applicable on us, who is responsible, how we are going to do it, what are the timelines, and how to move forward, and all that stuff. And based on this and a lot more, how to do strategic planning and have goals that we need to have smart goals moving forward. Then this is absolutely one of the vital things, because in healthcare, it's a human resource intensive industry. So making sure that we have privileging of providers, we need to make sure that we also train people on telehealth security training. So that has to be there. Then there are different classes, including passwords, access. How are you going to do that? Make sure that patient's confidentiality is there. How to make sure that there is no data breach, there are no spams, this and that. So this is just an overview of, and as we always say, that this is a journey and this is not a destination. And it's always a challenge, especially in this new domain. But telehealth is going to stay, and we need to make sure that we continuously embark our journey, and we are on that journey towards improvement and patient safety. Over to you, Julia.
Thank you very much, Dr. Zeeshan. So useful to see the outline of the components that need to be taken into consideration while you start thinking about improving the safety of telehealth. This is super useful. I would print out your presentation and just post it on the wall and use as guidelines. By the way, thank you very much for posting your questions so actively. We actually receive lots of questions already, so looking forward to our question and answer session. And lots of questions actually relate to regulations and governmental bodies like ministries of health, etc., how to seek support from them while providing remote care in telehealth, etc., etc. So I'm happy to introduce our third speaker, Dr. Bradley Beira from South Africa, medical legal advisor and member of the board. So probably Dr. Beira already answers some of your questions. If not during his presentation, then definitely we'll cover them during the question and answer session. Brad, the floor is yours.
Julia, thank you. And thank you to my esteemed colleagues who did such a good job, which now makes it very difficult for me to follow, because they're so eloquent of what they've done. To all of you, I apologize for being new. I saw my first patient as an undergraduate in 1993, and I've only been doing medico-legal risk and the landscape of medico-legal risk since 2007. So this is relatively new territory for all of us. And I say that because some of the tests, when we look at will this work or won't this work, go back to the 1600s, the 1700s. So when we talk about the medico-legal considerations of telehealth and digital healthcare, we're only going back to when the telephone was developed, because the telephone was developed and was used in the 1900s. And one of the adverts that I always think about when we have these kind of conversations that says, if you're stuck at home because you're quarantined and you know somebody who needs care, and this was during the smallpox epidemics, then phone them and reach out and say hi. And so that was what telehealth was like back 70, 80 years ago. So times change and things change. But what I did want to do, and Raju and Dr. Zeeshan, thank you for your amazing presentations. I want to show you this digital health ecosystem, which was released last year. And you'll see at the bottom, around about 6 o'clock to 7 o'clock, if you were imagining this as a clock, there's telehealth and telemedicine. That's the service delivery. Now, in some territories, in the European Union, in some areas, different in the GCC and different in India and different in North America, Canada and US and different in other territories, telehealth and telemedicine, the words are interreplaced, and sometimes they mean the same thing and sometimes they mean different things. But I think what's very important for us to take cognizance of and be aware of is that behind telehealth and telemedicine are the standards that we need. And I'll talk a little bit about that because there's different standards in different parts of the world. Then there's also the interoperability. And what that means is, how do we get our medical devices and our mobile devices and our static devices to speak to each other, to do the API, the technology handshakes, the application interface, and how do we get them to behave? And then what technologies are we using to collect data, to use that data, to store and process that data, and under which laws and regulations
تحت أي قوانين يمكن القيام بذلك.
Are we doing that? So those are things to consider. On the other side, when we look at our country, whichever country it is, what are our government's regulations? What are the e-health and m-health requirements? And then two of the things that we've spoken about, and you've had a lot of questions about that, what is the digital health literacy of your patient and their family, of your practitioners, of your allied support staff? Because one of the things that's a challenge is, I might know how to use a digital device, but you might not. Or you might have an understanding of what it can do, and my understanding might be different. And we often see that leads to discontinuity or confusion of care. And then the final things is social networks. I'm going to show you some risks about that in a bit. But then also the use of big data. When we start collecting this data, one of the biggest questions is, who owns that data? When is that data yours as personal data? When is that data the aggregate data of the service provider? When is it health systems data? And when is it public policy data? Because in each of those areas, different rules will apply in terms of how to access that information, how to share that information, how to preserve that information, and even in some territories, where to forget that information. You also need to bear in mind with all of this in the digital ecosystem, I might be a citizen of one country, receiving care from you in a second country by a clinician registered in a third country. And so some of those cross-border challenges of, am I licensed to provide care in the country that you're in to the citizen that you are, is something that we're starting to see come up from a legal and medical legal point of view. So it begs these questions. We're living in a world where we have transformative technology. This picture was taken, we were up in a very rural area. When I say very rural, from a major city, we were 12 hours drive. This was on the Angola, Botswana, and Namibia border. And this dongle was an ultrasound dongle that was allowing us to have a conversation from the southern tip of Africa with clinicians in Zurich. And so we've transformed and made our world very small in how we're able to discuss things. But now we've got to ask ourselves the question, and these are questions for you to ask in your care delivery system where you are. How do you define a consultation? Can a virtual consultation be part of value-based care? And where do the beginnings and ends of that consultation happen? And in defining it, are you educating both your clinicians, your healthcare providers, your consumers, and the users of your care, so that that understanding is end-to-end? And is this type of care that you're offering in your consultation person-centric, number one, and interoperable? Can we transpose it? Can it move across regions? Can it move across zones? Can it move across facilities? And one of the best examples of person-centric, interoperable, low-tech care was an immunization strategy that was done in Afghanistan a few years ago, where the child got a bracelet. And when they got their first immunization, the bead was color number 1, call it red. Wherever they went next for the next immunization, if they had a red band on their bracelet, the next bracelet band was yellow. And then the third one was green, and then the fourth one was blue, because that allowed there to be a continuity of care. One of the things we've got to bear in mind as we create telehealth ecosystems is that continuity of care is key. So when we start looking at what we're serving up, and when I say we, anyone in the administrative space who's creating a telehealth, telemedicine, digital ecosystem, the first part is there's a notion that it will allow for personalized care, genetic care with alleles, interoperable records where we can pull up your record at any time, your known dosage sensitivity to specific drugs, your specific needs, your compliance regimes could form part of personalized care. And personalized care could also be a triage system of who needs to be admitted and who needs home-based care. So that can, in the personal care area, create a nexus of admission into hospital, high maintenance home care, self-care with self-monitoring. And the second piece of that means that we would expect it to empower the care team, multidisciplinary care teams, sharing same and similar information, owned and curated potentially by the patient, with the hope in the third piece that it improves operational outcomes. Now, one of the things when we talk about this is there's a big difference between IA and AI. And so when we look at care and we look at medication safety, or we look at admission to discharge rates, or we look at ICD coding, or the DRGs, the diagnostic related groups, and the DTPs, the diagnostic treatment pairs, you can use IA, which is intelligent automation. When we start talking about using that information to create complex diagnoses, now we're moving into AI. So you need to be quite clear as you adopt technology. Are you doing IA-based bot technology, or are you relying on future, I use fringe in the delicate, respectful term, diagnostic acumen of machine learning and automation? So by definition, for us to be aware of, medical law is the body of rules. Now, I've put in here the rules of providing access to healthcare within the Constitution of South Africa as an example, because I'm speaking to you from a very rainy, cold, wet Cape Town today. But wherever you are, you would need to make sure that your medical laws, by your constitutions and by your healthcare provisions, are considered when you create your structures. So these rules would relate to all healthcare professionals. It would relate to the relationship between your clinician, your user, and your consumer and your user may be different, and your hospital or your care facility or your home-based care network or your tele-rehabilitative network. Then you'd also bear in mind that this relates to all of the rules between medical professions and all healthcare professionals. So whether you're in prevention, early diagnosis, secondary care, rehabilitative care, epidemiology, clinical trials, all of that is governed by medical law, and all of that sits under the healthcare legislation. So I wanted to give you an example of this. And recently I had this as 12 slides, and the group that I spoke to said, can you put it into one slide? So this is the one slide. You will have legislation in your organization that you need to manage. And you would have to look at that legislation within your country. What is your country and and possibly your country has interrelationships with other countries. So what is the constitution, your statutory laws, your agency laws, and your case laws say about what's required of you and your burden of care in your country? That's your legislation. Off that comes your regulations, and your regulations then speak to what your scope of practices are. And those could be your hospital scopes of practice. They could be your clinical scopes of practice. They could be your pharmacy laws. They could be your public health laws. But those two sets of laws then define the guidelines that you work on. So when we talk about guidelines, specifically in telehealth and telemedicine and mHealth and eHealth, you can see there that all, on the right-hand side, I've given you a list of some of those that you need to be aware of. Your continued design guidelines are the guidelines that mobile devices now have to ascribe to, and that's been around for several years, but there's been a new definition between own use and medical use devices, because the sensitivity of your oximeter or your blood pressure cuff or your glucometer is significantly different in a medical device versus an own use device. So you need to bear all of those things in mind. You also have to bear in mind, if you're building this network for the first time, that you have what are called the FHIR standards, which are your fast healthcare interoperability resources, to make sure that the continuous guidelines and the data sharing is done. Then I've included with you a couple of the acts, but some of the most important ones, your 21st Century Cures Act, your Digital Healthcare Partnership, HIPAA, all the way through, which is the US-based information sharing, the GDPR, which is the European Union-based, PIPEDA, which is North America, Canada, POPI, which is South Africa. Those are all examples of data protection structures, making sure that as you go through healthcare, your diagnosis, your coding, your finance, your use and access to data meets both those standards. You also need to make sure that whatever ecosystem you're creating, you need to make sure that all of the other countries' data privacy and healthcare privacy rules are also met, especially if you're doing remote second opinion work, or you're doing medical tourism, or you're providing remote interpretation. So there are the JCI guidelines that Dr. Zeeshan spoke about. I've also shown you there's the telemedicine practice guidelines from India and the AMA guidelines, which are fairly contemporary, which would give you 3 or 4 different styles of what you need to consider. The AMA has a 12-step process, and the India guideline an 18-step process to contemplate, if you're going to set up a telehealth ecosystem, what do you need to consider, from the kinds of software, hardware, and data integration and data storage systems, to the education of your care teams, to the data security that you need, to the templating that you would need for your electronic records and device interfaces. So let's assume things go right. Fantastic. When things go wrong, you can end up with the regulator in your region taking disciplinary action against healthcare providers or clinics or hospitals or administrators. There's also the civil action that can be taken for negligence, and the criminal action that can be taken in the event that the state prosecutes you in terms of a failure of care. What I wanted to do is just give you some examples post-COVID that have come out as telehealth risks. The first thing, and we know this as a general rule, is that the biggest issues when there is a litigation or a claim against a healthcare practitioner, and usually when there is a claim against the practitioner, there's also a claim against the institution and any governing body that surrounds that. So it's the primary complaint is a failure to diagnose or a delay in diagnosis. Now, as you can read these for yourself, you can see there's complications from treatments, there's poor outcomes and disease progressions, and failures to treat and delayed treatment. What we know now is that some of the challenges on the first several hundred cases that have been reviewed post-COVID is the complaints have been, you didn't examine me properly remotely. And because you didn't examine me properly, there was a failure or a delay in my diagnosis. And because of the delay in my treatment, there was a poor outcome and my disease progressed further than it could have. And so when I ask you to think back first to my slide that says, what is a consultation? And then both to my 2 colleagues on their presentations in terms of how they defined digital care and how they've used it in their organizations. How good are you within your organization, upstream from where you've conceptualized this use to downstream where it's being applied, at making sure that the patient understands the limitations of what your healthcare can do? When we look at OECD, the OECD countries, and we look at the adoption of telehealth and telemedicine, we find that certain types of healthcare, there's a much higher adoption, psychiatry, psychology, social care, triaging for primary healthcare. But as the diseases become more complex, and as we go into neurology, ophthalmology, orthopedics, the use tapers down because your need for face-to-face visits increases. So one of the things that you also need to be aware of is the danger of a social consultation where you don't have all the imagery. So that plain film that you can see, where you see what looks like a lung underneath the chest, is actually a tree, because the plain film X-ray is being held up to a windscreen, and through the windscreen you can see the tree and other things. But also the angle that the X-ray was taken at suggests a far greater or more severe injury than was actually there. So when somebody writes and says, well, what do you think? Or do I need care? Or what should I do? That is not telehealth. You need to enter into a mutually binding therapeutic relationship where both you as the provider and your care partner and your patient understands what you can and can't do in a digital space. So here are some of the things as I wrap up, because I want to make sure that there's plenty of time for questions. The 4 most common areas of medico-legal risk, as we're seeing now in telehealth. The first is the delay in diagnosis and care, which falls typically under the area of negligence. And here we would talk about the reasonable person test. And in law, the reasonable person test came out for the first time in 1703. So it's still a relatively new law. But it says, what would a same or similar person with the same or similar education as you do in a same or similar circumstance to get a same or similar outcome? So if we're now testing to see whether we did a good job using our mobile device, and when we use our mobile device with its screen, could the screen give us enough resolution, and could our examination be thorough enough that had we been there, would we have been able to do it? But for our actions, did we do a good job? The second is the social media and the disclosure issues, promising something we can't deliver, giving scientific advice versus opinion, unintentionally sharing or disclosing people's health status is a big deal. The third, which is a lesser deal, but is much more relevant, is the issue of how well you keep consent. And I say it's a lesser deal because when people take action against one for an adverse outcome, it's the adverse outcome that's important. The fact that we haven't taken consent or done appropriate consent or kept the records suggests that we can't defend their claim of negligence. So our record keeping, which is much harder in a digital environment, unless you're recording and transcribing and disclosing that you're planning to do that, has challenged. And then the biggest dot that you'll see there is the dot of data breaches. And as of today's call, there was a major data breach on a US-based health system where both there was a ransomware component where they couldn't access their systems, but also the clinical records, including diagnosis, prognosis, treatment, were removed. Now, that in itself is not a crisis unless the person suffers harm as a consequence. So we've got to bear in mind that there's a relentlessness in terms of cyber attacks and cyber terrorism and cyber theft, that if we're moving into this world, and we're in this world, but as we go deeper into it, we become increasingly aware of the importance of breaches. So I'm going to hand back at this point and say thank you very much for listening. I'm sorry that it was very fast, but Julia, thank you, and back to yourself.
Thanks a lot, Brad. This was very interesting. And now I have a feeling that the number of components to be considered is really growing like a snowball. So I'm sure our audience is pretty scared by these multiple things to be taken into consideration. And I can tell that judging by the number of questions that we received, I think it's the biggest number of questions ever we received during our webinars. So let's start our question and answer session. And the first question basically relates to the basics, the question of regulations and the question of license. This is one of the most repeated question today. So number one, are there specific licenses required, considering that we have hospitals and medical facilities from all over the world? How would you know that license is required or not required for your country specifically, especially for the countries that actually actually do not have clear regulations regarding telehealth. There are such. So some developed certain standards and regulations, some did not. And actually the comment was that sometimes the legislation is behind the innovation. So what should medical facilities do in these conditions? If they want to do telehealth properly, but the country doesn't give any regulations yet. So who would like to start? Yes, Brad?
If I may start, and then I'm sure my colleagues have a lot to say as well. I think the first place that one needs to go is to what the scope of practice is in your country for that type of care. So primary care, secondary care. So by primary care, I'm talking about general practice, diagnosis, and that could go from nursing all the way to general medicine. That scope of care could be very different from the scope of care of a specialist who has a limitation in their scope to what they may or may not do. So what you would need to do if you're in a hospital and you look at your OPD, for example, your outpatient department and your pharmacy, and then you would look at your admissions, and then you would look at your surgical and post-surgical and discharge and post-discharge work. You would need to look at that and say, what within my country is the requirements? Now, I know most countries, by far the majority that I see are on the call today, have an e-health white paper at least published that is giving a guideline that says, this is how we regard healthcare in our country to be, number one, and this is what we regard digital health to include and exclude. And I think that would be your first step. The second step to that would be to say, are there any restrictions in terms of things like the electronic communication of data? So what are your personal privacy, like GDPR or POPI or PIPEDA or other restrictions that require you to hold data in a specific way? Because how you hold your patient data or your special personal data will define the kind of environment you need to create. So those would be my first two steps, Julia.
Thank you very much, Brad. Dr. Zeeshan, any tips from you?
I think I would like to echo what Dr. Brad has said. As Dr. Brad has also mentioned, so it all depends that which country you are in. That's number one. Number two is that what are the applicable regulations? And it's not only about e-health. There are privacy laws. There are what are they? What about licensure? Or what about, can you provide those services while you are within this country? Are your providers within the same territory or they are somewhere else? So there are lots of factors. What are the licensure requirements? Is there any peer involved? And if there is any peer involved, what are their requirements? So there's no absolute right and wrong answer. And I would like to echo what Raju has said, that currently the pace with which telehealth and digital health that's expanding, that is, all the regulations, compliance, they are not catching up with the pace with which it is expanding. But it is here to stay. So it is important that whenever we decide that we are going to provide any service, as part of the planning process, we need to make sure that we identify that, well, these are the laws and regulations. If we don't have, are there any other laws and regulations in other countries that are applicable and how to use them? Are there any standards available? Yes, these are the various standards available. Which standard suits us the most, or there are standards that are quite strict. Are there any standards that we can start with? And then we need to graduate to a certain level. So there are lots of ifs and buts, and it all depends upon the situation of the organization that particular organization is in.
Thank you very much, Dr. Zeeshan. Very valuable. So basically to the question, if nothing exists in the country, can we still do telemedicine? There were such questions. Yes, you can. If nothing exists in the country, go and look at the examples of other countries that already developed best practices and standards for safe provision. Raju, you wanted to say something as well?
No, I think I echo my fellow panelists. I think there is regulations and then there is self-imposed regulations, right? So you can actually, if they say like is like I say, I call it the no U-turn sign. If there's no U-turn sign, you can make a U-turn, but then do it carefully and cautiously without endangering your patients, without risking your patients' lives. So I think, and you can. The good thing is you can learn from many markets, mature markets. They have done it correctly, but it may not be 100% applicable to you, but you will know how the most stringent standard is, and then you can adapt and you can evolve over time, and in delivering care safely. So you can always learn, like if you look at the Brad mentioned about the telehealth standard in India guidelines, it's very, very prescriptive. It says like the first consultation has to be in person, and the subsequent consultation must be by the same physician. It's very prescriptive. So you can actually take some of those and adapt to what makes sense for you and your patients. But at the end of the day, the bottom line is do no harm, right? So I think that's what we want to do. Thanks.
Thanks a lot, Raju. Brad also wanted to say something. I just wanted to remind you that in Brad's presentation, there was a link of several links to resources that you can possibly use. Yes, Brad?
I think one of the things that you may want to bear in mind to all the delegates on the program is if you have a registering body for medical devices, and you're planning to use medical devices for monitoring diabetes, weight, blood pressure, SpO2, or anything else, you need to make sure that the relationship between your device regulator and yourselves is close as the first instance. In the second instance, and this then goes to reimbursement models as well. If you're being reimbursed by the state, you need to understand what the state's ICD coding system would look like. So I think by far the majority of coding systems are still ICD. There are one or two that are SNOMED, but you would need to make sure, whether it's a private funder or a state funder or a joint funder system, what billing systems are used, what medical switches are used, what coding is needed. And then the lesson from Portugal as an example is that there is an incentive for telehealth for patients from peri-urban and rural areas. And there is an incentive for health for persons who are frail, disabled, limited mobility, and potentially infectious, because the public risk of them going out into the public and using public transport is greater than the cost of a single consultation. So you may need, if you don't have that, to negotiate tariff rates, but you may find that there's already tariff rates contemplated. You just need to make sure that your channel of billing matches that which is acceptable.
Thanks a lot, Brad. So now we talked about the basics, the foundation, the guidelines, the standard, and the legislation. So once you stop thinking about setting up telehealth properly, next comes the level of capacity building. So basically training for the staff. Lots of questions on this. How to train staff properly, what training is obligatory, and are there any resources that you can recommend to get knowledge on most effective training, etc. Brad, do you want to be the first?
I was going to say, I think Dr. Zeeshan, who's walked this journey, is probably the best to give this response.
Sure.
Okay.
Dr. Zeeshan?
So thank you. Again, there's no absolute right and wrong answer to this question. First and the foremost is identification of your human resource, available human resource, different categories, identification of different categories, identification of your scope of service. What is your scope of service? Because as far as this telehealth is concerned, there's a huge scope and it can vary from organizations to organizations. So in order to identify that what needs to be trained, you need to identify that what type of human resources there, what are the services you are providing. And then based on that, you need to come up with a program. So when we specifically talked about, so there are certain programs that are there that are applicable on healthcare, like credentialing of medical staff, privileging of medical staff, competencies of nursing staff, those people who are providing there, of technicians, making sure that what type of orientation is given to the staff, do you take them on board, this and that. But specific to telehealth, there are certain specifics that we need to train people on. That is one. That about as small things as small as using passwords, sharing passwords, as small as using devices, which device to use, as small as using VPN, if you have an organization, how to make sure to have your policies and procedures built around all those, all that stuff, making sure that that the staff, they know how to maintain confidentiality of the patients, how to be careful and mindful of the fact, because some people
أن يضمن
yeah.
إذن سرية المعلومات الخاصة
Julia, can we please mute? Thanks a lot.
Yeah.
الخاصة
So I think they have changed the
المرضى.
channel or something. It has.
أعتقد أن شيئا ما قد حدث.
No. Can they please
Yes.
translate? Can they please translate in Arabic channel?
Yeah. Yes.
I think
So,
if I may, Dr. Zeeshan, this is a very good example of the challenges that we face sometimes. We very seldom get
That's right, Brad.
مثال جيد
Absolutely.
على
face-to-face
التحديات
No.
But in a consultation
التي
online, it
نواجهها.
can happen.
No.
Yes.
Sorry.
So,
Translators, please go to the French and Arabic channel because we can hear you in the main channel.
So I think Brad was spot on in saying that what to do in case if everything is not going fine. So because in a healthcare facility, you have a lot of support available. So what are the backups? What is your first line of defense? What is your second line of defense? What is your third line of defense? And then making sure that how to, for example, if there is a consent, if there is patient privacy, if there are, how to maintain patients' rights, how to make sure. So it's not only about training of your own staff, it is also about managing expectations of your patients. It's also educating them. So it's a challenge, and we must say that it is a growing field, and we all are learning, and it is a process, and it is not a destination, and there are no absolute right and wrong answers to those questions. So it is just that we, and last but not the least, we need to collaborate. Wherever you are in the world, it's important that we collaborate. It's not about competition. Healthcare, it is such a green field, especially in the developing world, that there are lots of opportunities. So it's always good to shake hands, learn from each other, share your experiences. So I think those are some of the things that come at the top of my mind. Over to you, Julia.
Thanks, Dr. Zeeshan. Yeah, actually, if no comments from other speakers, we can take another question. And another question basically covers another component of setting up a telehealth system. That's the scope of services. And speaking about the scope of services, we received a very specific question which made me puzzled. That's remote surgery. Does it exist, such thing as remote surgery? That's number one. And number two, also speaking about scope of services, let's also talk about maybe like phased approach, because as Raju described, India has specific regulations regarding starting with a real life consultation and then continuing virtually. So should we limit scope of services that we have for remote consulting, or we can provide everything? Thanks a lot. Brad, you had a hand. You want to be the first?
Sure. Maybe we need to divide this into two things. I think telehealth as a way of triage in a high volume area is one thing. Telehealth first consultations, because there is no clinician in a peri-urban, rural, or remote area, is something else. So you'd need to do a needs analysis of your population, a little bit of an epidemiological assessment, and say, well, who is our need? What is it for? Which conditions do we need to address? Can we send nurses or health technicians to those remote areas? and do facilitated care. So that's one type of answering your question. The second type is there are very good technologies right now that triage early diagnosis and say to the patient, you need to go to this room or that floor or that clinical setting to get that type of care. So that's the second piece. When we start talking about remote surgery is done, as is remote interpretation of MRI, CTs, diagnostic ultrasounds. Equally, it's done for remote interpretation of blood work. Again, you would need to look at this and say, what's appropriate in your area? One of the things about remote surgery, and I remember spending some very interesting time in Kenya and saying, well, this is a great technology, but do we have enough bandwidth to make sure that the procedure goes end to end without data interruption? Because if I'm doing something remote and the pipe is this thick, but there's no water going through it or there's no data going through it, you can't do the surgery, you can't do the procedure. So robotic remote surgery is being done, but it's highly specialized in highly unique areas. And I think what we need to recognize when we have these conversations, there's the nascent desire to implement early strategies on pilot basis in highest needs to where there's highly technical, sophisticated care being given at centers of excellence. If you want to become a center of excellence, recognize it takes 2 to 3 decades to become that, but it starts with a pilot. That's my experience.
Thanks a lot, Brad. Dr. Zeeshan, Raju, anything from you on making the scope of services in order to avoid incidents and problems? Scoping for telehealth?
Yeah, Julia, I think as Brad mentioned, I think we need to define what is that we want to do. And as I say, you sit down before you stretch your legs. So remote surgery is very much possible, but I wouldn't start with that, right? So obviously you might want to do using cases, and you will get to there someday, definitely. But start simple, look at what you can achieve within your country context and within your facility context, what kind of expertise you have today to deliver what kind of care. So that will help you to define the scope and do in phases. And because if you do things wrongly, to recover from that is going to be more challenging than not doing it at all. So I think you've got to be very, very careful. Thank you.
So,
thank you very much, Dr. Zeeshan.
Yes. Yeah, just adding on to, I think, wonderful comments, just adding on, whenever we are defining the scope of service, it's extremely important that we define what we cannot do. Because once you identify that this is what we cannot do, these are the patients we cannot see. So then it's sometimes it's easy for the staff to understand and comprehend that, okay, these are the things that we cannot do and these are the things we do. So if such sort of patients come in, so you need to have checklists, you need to have your algorithms, right, flows all there, so they would know that if this happens, they're going to refer this patient over there. So the staff should know, one, when they need to know their limitations, and then they need to know how they can call for help. So if something they don't know, there's a gray area, there's black and there's white. If there's a gray area, how they can call for help. So scope of service, the more emphasis you can give up on that, especially its safety component, in order to provide safe care, it's extremely important that the leadership defines the scope of service, the staff, they understand the scope of service, and then the patients, they also need to have access to that information. So a lot of a huge triage is being done before even the patients come in. They would know that this is the place to go and this is not the place to go.
Thanks. Very valuable, Dr. Zeeshan. So next question, actually, Brad mentioned earlier technology. So we received a very specific question. Can WhatsApp be used for telehealth? And speaking about WhatsApp in specific, what other platforms are safe or not safe for use as social networks, telephone? What are the possible scenarios and what we should avoid? Brad, do you want to be the first?
Maybe. I want to be the unpopular first. In the perfect world, we would use encrypted two-factor authentication with secure sleeves on beautiful platforms. The difficulty we have with that is they're not always affordable, number one. They're not always accessible, number two. And by accessible, they need technicians, hardware and software, bandwidth, back-end support, technical support, and subscription. So whilst that's the gold standard and what we should be aspiring to, the reality is in many environments, the patient might not be able to afford it. The volume in the clinical hospital might not be sufficient. The local country or the remote area might not have the technical support to allow that to happen. So what you need to do is take all the reasonable precautions that you're able to take to make sure that what is communicated across that technology is safe. And so let's say that you raise specifically WhatsApp. So I like WhatsApp. WhatsApp is encrypted in theory. It's not the WhatsApp that's the problem. It's the device on this side and the laptop on this side. So now if my device doesn't have two-factor authentication and your device doesn't have password protection and somebody steals one of them, then they have access to all the records. So it's more the issue of how you secure the devices than it is which platform you use. And in my informed consent up until now, I've said to patients, I will communicate with you on WhatsApp when it comes to the sharing of information that's necessary. But I am accountable that when I receive that information, it's transferred into my electronic record, which has two-factor authentication. My biometrics switch on and off my laptop, and my different biometrics are needed to access my EMR. So I think that's where the key comes in. Your cyber protection issues are more important than the platform that you use. You may use Zoom like we're using Zoom now. You may use Teams. You may use Google Meet. There's no prescription that says what you can or can't use. I think the key issue, and I defer to my colleagues for their comments as well, is that it must have end-to-end authentication and security for access.
Thanks a lot, Brad. Dr. Zeeshan?
So I would like to build up on what Dr. Brad has said. So it's not about the platform. It's about the policies and procedures around and how you design your service. That's the most important component. So before you think about a service, you need to plan and you need to see beyond the wall to see that what can happen and what cannot happen, one. Number two, you need to be very transparent. As Dr. Brad has said, you need to be sure that your consent includes the platform or the platforms that may be used, because we don't live in a perfect world. So there is a possibility that you start with one platform, at the end of the day, it does not work, or the patient is not able, if patient is managing the other side, maybe patient is not able to connect. So what are you going to do next? So the point is that it's the policies and procedures that are framed around your service that is more important than which platform do you use. So I think that's and last but not the least, once you have your policies and your framework developed, then how well do you train your staff and how well you keep your patients informed and how you keep yourself legally protected. So I think those are the things that we need to keep in mind while answering all these questions.
Wonderful, wonderful, Dr. Zeeshan. Thanks a lot. Very useful. Raju, you wanted to say something?
Absolutely. I think the bottom line is your own policies and protocols that is going to dictate, not the platform, because even we tend to be more vigilant in person, but then when it comes to remote, you kind of take it very lightly, because sometimes I've seen clinics when they want to convey test results or whatever to the patient, if they call the patient, they will just assume that it is the since I called this number, I just assume that it is Julia on the other end of the call, and I will just say, is that Julia? And you say yes, and then I give you your results. That doesn't work that way, right? Because banks do that very, very carefully, right? When they want to talk to you, they want to ask you for a few identifications, and they ask you some security questions. But then when in a clinical setup, sometimes I've seen it being taken very, very lightly. So it's actually your protocols that define, not the platform. Thank you.
Thanks a lot, Raju. So before we move to the next question, actually a comment that I wanted to make. We receive lots of questions which relate to ethics, and I wanted to invite you to our, just to tell you first of all that in IFC we have a community. You can adopt our ethical principles in healthcare, and I will ask my colleague Maria to share in the chat the link that you can use to subscribe. It's free of charge, and there in the community, lots of ethical issues are addressed, and I'm sure you will find lots of answers there. And the next question, once we are going component by component of the telehealth system, is actually measuring. Measuring success, generally indicators to make sure that the program is going on safely and successfully in telehealth, and specifically measuring patient outcomes. How do we do that? Any tips where to read about it, etc.?
I can, okay, Brad, yeah, Brad want to say something. Yeah.
Okay, Brad, please.
I always want to say something, Dr. Zeeshan, so you have to be fast with me. There are many research articles published of experience. If you go onto PubMed as an example, and you type in clinical outcome measures for telehealth, there's probably 400 or 500 articles. I think the most important thing is to look within your health ecosystem and say, what are our measures of success? If your measures of success is the number of new consultations, the number of follow-ups, maybe the number of dispensing medicines that reach their target individual, compliance with those medicines, it would be very dependent on the type of service you're giving. Dr. Zeeshan, you're living this experience, so I defer to you.
I think I'll build up on what you have said, Brad. It's said you cannot manage what you cannot measure, and anything that gets measured gets done. So it really depends upon you. There are lots of indicators. So it's not about in this global village where we are living in. So the data is all around us. Resources are all around us. It's just a matter of what we are doing, what we want to measure, and what is our measure for success. So it's whatever you want to do, just start measuring it. And it's said you cannot manage what you cannot measure, and anything that gets measured gets done. But there's a caveat to it. That is that we need to prioritize. It's because sometimes we have hundreds of measures, and at the end of the day, we don't know what to do with them. That's one. Number two, we don't identify that when there is a special cause variation, and whether if there's any change, do we need to act at this point in time or not? So it is important to identify that when and how to act, how to escalate. So again, it's not about the measures, it's about the framework that is all around it, how you manage those indicators, and what do you do next. And last but not the least, how to identify that an improvement has been made and then improvement has been sustained, and how to move on to the next measure. So, there's no absolute right and wrong answer, and whether it is telehealth or it is healthcare in general, the principles remain the same. It's just a matter of applying them in, and you cannot say that these are the specific telehealth indicators that we are going to use. Technology is a way of providing that service that you are giving to your patients. So that should not dictate what you want to do. At the end of the day, we want to deliver safe, affordable, accessible, evidence-based, and timely healthcare to our patients. And in order to do that, we use different techniques, different technologies, so they are all supporting. So I think that's what I would like to say at the top of my head.
Thanks a lot, Dr. Zeeshan. Wonderful concluding remark, Raju.
I think it's correct. I think first we need to decide and define why you want to do telehealth. Then you see how you want to measure it, right? Because as Dr. Zeeshan and Brad said, if your primary objective of setting up this service is to improve accessibility to care, then you measure that. How many new patients, how quickly patient can get an appointment, those kind of accessibility to care. But if your primary objective was affordability for, say, for chronic conditions, if you can reduce the patient cost for chronic condition by eliminating multiple in-person visits and stuff like that, then you start measuring that. So define why you want to get into telehealth, and then you can define, okay, what I want to measure. Oh, it could be patient satisfaction, anything. So the measurement can be a very, very wide bucket. So decide what you want to do, and then start measuring and then managing. Thank you.
Thanks a lot, Raju. So I think we will need to be concluding now, because I'm being conscious of time. Your questions keep arriving. Thanks a lot. We'll definitely need to think. There are lots of practical questions or how-to questions. So we'll think internally which will be the best way to address them and to answer them for you. I want to introduce Natasha, my colleague. You know her very well. She didn't have, for technical reasons, a chance to address you, to tell you some important things at the beginning. So now, Natasha, the floor is yours. Natasha, you're on mute.
Thanks. I was probably overly excited to speak to you at the beginning of the webinar, so the internet connection did not hold this excitement. Today is our 30th webinar, and at each of our webinars, this is number 30, and at each of those webinars, we keep getting questions about where to find the recording, where to find other useful materials, and if there are any certificates. So let me just answer those questions maybe in 2 or 3 minutes. Let me get you to the slides, my slides. And basically, so where can you find the recording of today's webinar? You can find it on our IFC Healthcare YouTube page. Let me see if I can move this one below. Yes, I can. So our YouTube page is called IFC Health. And there are some people watching this very moment there, our live broadcast of this webinar. And there are also previous webinars there. So this is where you go if you want to repeat something, or if you had to step out and you want to catch up. So this is what you type in your browser, IFC Health. And YouTube, or you can go to YouTube and type IFC Health. So this is it. Now, our previous webinars are also available on our IFC page. And if you type IFC Healthcare Webinars just in your browser, so the first link you're going to get, IQ Healthcare Webinars and Trainings. And this is exactly what you need, because this is the page with our webinars and trainings. Now, speaking about trainings, what do we offer? Like, not only webinars, we also offer online trainings. Those are free. Those are online based. You register and you do not have to pay anything. They're self-paced, meaning you can take a part of the training, you can stop and you can continue at another time. And they also offer certificates. This is what a lot of you would like in exchange in your time. Sometimes it's possible to award certificates because we can actually measure your progress. Sometimes, like with webinars, it is not, but for trainings, we do offer certificates. And basically there are 10 trainings available so far. So there are 6 of them on IPSG and another one on patient isolation. We've got 3 trainings on quality management, foundations of quality management, incident reporting, and performance management. These are the 3 core subjects that you would like to study. There are 10 of them, and there will be more. And for each of them, You take the training. When you complete it, you pass a quiz and you pass it. If you pass it satisfactory, you can get a certificate mailed to you. So this is important, I think. Also, we do have our page, which is called IFC Healthcare Tool. And this is where you can find more information about what we do, how we do it, about hospitals, about the healthcare quality assessments. And if you want to go even deeper, where do you go? You go to our Facebook community of practice. And on Facebook, and you will receive a link. Each of you will receive a link to that community of practice in an email. Now we are going to send each of you who registered for this webinar an email in a day or two that will contain slides from today's webinar and links to all of the resources that are that I have just listed. And in exchange for that, we only ask to do one small thing. We ask you either to fill out a survey on exit, telling us how good we did. I mean, what you liked, what you didn't like, what you want, what else you want from our webinars, or you can send an email to us in response to our invitation and basically talk about the same things. And that's it.
Thank you very much, Natasha. I hope you will find it informative and useful. Please join, use all our links. This is, I believe, very helpful. Thanks a lot once again to all our brilliant speakers today. Thanks a lot to the audience for joining and being so active. Look forward to seeing you soon, joining our next webinar, and enjoy the rest of the day. Bye-bye.
Thank you. Bye-bye.
Thank you.